Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. This episode will mostly focus on benign ovarian masses, and the next one or two episodes will focus mostly on malignant ovarian masses. A free study guide on the topic of ovarian masses will be released on theradiologyreview.com once these episodes have been posted. I want to take a moment to note that the Radiology Review Journal is now the Radiology Review Insider, and there are a few new articles that have been posted, including one excellent article by an external author called Radiology Resources, the list every medical student needs. This article has a lot of very helpful information for medical students and even residents in terms of links and suggestions to access educational radiology content, including anatomy helps, YouTube and social media resources, and a myriad of other helpful resources that I think may be helpful for many of you to know about. So go ahead and check that out. I also recently released a post called Radiology Residency 10 Maxims for Success in 2022 that you can access for free at the Radiology Review Insider at theradiologyreview.com. Without further ado, let's get into the questions and answers for this episode. First question: what are key imaging features of a hemorrhagic cyst? A hemorrhagic ovarian cyst occurs when the granulosa layer within a corpus luteum ruptures and bleeds. This is a common cause of acute onset pelvic pain, although hemorrhagic cysts may also be asymptomatic. On ultrasound, the appearance can vary based on the age of blood products within the cyst. Typical features on ultrasound include what has been termed lace-like reticular echoes within the cyst. Go ahead and look up images of that if you don't know what those lace-like reticular echoes look like, as well as hemorrhagic cysts typically showing posterior acoustic enhancement and lack of internal blood flow on color Doppler imaging. Alternatively, with a hemorrhagic cyst, an intracystic clot with no internal blood flow can also be seen. Fluid levels are also sometimes seen internally. On MRI, one would expect a hemorrhagic cyst to manifest as an adnexal mass with no internal enhancement, most commonly showing increased T1 and T2 signal. Next question: when might a hemorrhagic cyst require follow-up? If on the core exam, an ovarian cyst with features of a hemorrhagic cyst is greater than 5 centimeters in diameter if premenopausal, or any size if postmenopausal, follow-up in 6 to 12 weeks with ultrasound or MRI is the best answer. Most hemorrhagic cysts resolve within about 8 weeks, so follow-up can help distinguish between a benign hemorrhagic cyst or another process. Next: what are key imaging features of an endometrioma? Endometriomas are the result of endometriosis of the ovaries, with repeated episodes of bleeding within the endometrial tissues located about the ovaries. Clinical symptoms of an endometrioma can include pain, as well as infertility, which can occur in something like 25% of cases. I usually think of an endometrioma as an ovary-specific process, but technically these can occur elsewhere in the pelvis, such as the pelvic cul-de-sac or the broad ligament. On ultrasound, a cyst with homogeneous echoes and posterior acoustic enhancement may be the most classic manifestation, but the ultrasound appearance of an endometrioma is variable and can less commonly include things like multiple internal loculations, fluid levels, and a mixed cystic and solid appearance. MRI is really important to understand for an endometrioma. MRI has the shading sign on T2. That is something you should know about. Look this up if you don't know what this looks like. Expect on MRI to see T1 hypointensity as well as low T2 signal in portions or the entirety of the cyst because of the recurrent hemorrhage with deposition of iron. In some cases, near complete loss of T2 signal may be seen. A hemorrhagic cyst would be expected to be brighter on T2 in classic cases compared to an endometrioma, which shows variable degrees of T2 shading. An endometrioma may show wall enhancement on MRI, but any enhancing mural, nodule, or mass raises concern for a malignant lesion. Now I need to make one correction here. I believe that I said that an endometrioma is HYPO intense on MRI on T1, but more classically, you should expect T1 hyperintensity, where endometriomas tend to be very bright on T1, with some exceptions when there may be only acute hemorrhage that can sometimes look hypointense, but I would remember that typically endometriomas are T1 hyperintense. Let's move on. Is follow-up indicated for an endometrioma? For the core exam, I would recommend choosing either surgical excision or annual follow-up for an endometrioma, given the small risk that does exist of malignant transformation. Additionally, keep in mind that therapy with a gonadotropin-releasing hormone agonist may also be considered. Next, what is the most common ovarian neoplasm in an adolescent? The answer I am looking for is a cystic ovarian teratoma, which accounts for over 90% of ovarian neoplasms in this age range. Remember, the large majority of these will be benign, something like 90%, and there is a risk of ovarian torsion, which may be the presenting feature. In about 10 to 15% of cases, cystic ovarian teratomas can be bilateral. Next question. What are key features of an ovarian dermoid cyst? A dermoid cyst of the ovary, at least for the core exam, is essentially the same as a mature cystic teratoma that I talked about in the last question. It is important to remember that these contain tissue from multiple germ cell layers. Technically, a dermoid has dermal and epidermal components, whereas a teratoma has dermal, epidermal, mesodermal, and endodermal components, but that is likely beyond what is commonly tested on the core exam. As I said before, these are bilateral in something like 10 to 15% of cases. On radiography, an ovarian dermoid may manifest as adnexal calcifications due to components of teeth and bone in the mass. On ultrasound, a dermoid cyst may demonstrate posterior acoustic shadowing and may show echogenic interfaces from bone that obscure underlying tissues, and that has been termed the tip of the iceberg sign. A Rokatansky nodule is a mural nodule that is frequently hyperechoic on ultrasound. Fluid levels can be seen. Internal echogenic bands can be a manifestation of hair contained within the cyst. No internal vascularity is expected on color Doppler imaging. CT imaging of an ovarian dermoid cyst will often show an adnexal mass containing internal fat, calcification or ossification, and possible fat fluid levels. MRI shows an adnexal mass with internal fat, which can be confirmed by techniques like fat suppression or chemical shift due to presence of microscopic internal fat. Solid components may show enhancement and raise concern for potential malignant transformation. Next, what are some of the signs of ovarian dermoid cyst rupture? In the setting of ovarian dermoid cyst rupture, fat and fatty fluid can be seen in anti-dependent spaces in the abdomen and pelvis, including spaces like just below the right diaphragm around the liver, which is a classic location for this finding. Clinical symptoms can include acute onset pain from a chemical peritonitis. Next, what is typical management of an ovarian dermoid cyst? If an ovarian dermoid cyst is larger than something like 7 centimeters, surgery is often indicated. If under 7 centimeters, a 12-month follow-up could be considered to document stability or identify need for surgery if the mass continues to enlarge. Ovarian dermoid cysts can commonly be very large, something like greater than 10 centimeters at presentation. Next question. A struma ovarii, that is struma ovarii, a struma ovarii tumor contains tissue from what non-pelvic organ? The answer I am looking for is that struma ovarii contain thyroid tissue. A struma ovarii is in the family of ovarian teratomas and is often composed completely or at least mostly of thyroid tissue. Struma ovarii contain internal colloid material. In about up to 10% of cases, hyperthyroidism may be present. It is important to remember that a struma ovarii cannot be differentiated on imaging from other ovarian neoplasms. On MRI, struma ovarii often show heterogeneous signal intensity on both T1 and T2 weighted images. Struma ovarii are mostly benign tumors that are often treated with surgical resection. Next, what are guidelines for ovarian cyst follow-up based on size of the cyst? It is important to remember that guidelines for follow-up of an ovarian cyst vary depending on size of the cyst and also vary depending on whether the patient is premenopausal or postmenopausal. For premenopausal patients, cysts at or under 3 centimeters are typically considered physiologic, and these include things such as a corpus luteum or ovarian follicle, and these generally require no specific follow-up. If over 3 centimeters in size, but equal or less than 5 centimeters, and demonstrating a simple appearance, no follow-up may be necessary, but these should generally be reported in the imaging report. If over 5 centimeters, some form of follow-up is generally needed, which initially is often follow-up ultrasound or MRI in the range of 2 to 6 months to see if it resolves, as in something like a hemorrhagic cyst, and subsequently, if not resolved or decreased in size on that initial follow-up, continued follow-up every 6 to 12 months for at least 2 years is generally recommended to ensure stability. For postmenopausal patients, criteria are more strict, and follow-up is generally needed for cysts that are over 3 centimeters in size. Again, initially at something like 2 to 6 months for resolution, and then every 6 to 12 months if it is not resolved or similar in size. In general, 2 years of stability for larger cysts requiring follow-up per the criteria discussed is necessary before these may be considered benign, especially on the core exam. If cysts are large or increase in size, surgery may be performed for resection and definitive characterization. And a few caveats here. These follow-up rules I've described are for simple appearing ovarian cysts. So these are cysts that do not show features specifically concerning for cancer at baseline. Additionally, follow-up criteria such as these may vary, and I would suggest that you consult with either your radiology attendings or published information on what the most appropriate follow-up is, as recommendations can vary and change over time. Last and final question. What are findings of ovarian hyperstimulation syndrome? Ovarian hyperstimulation syndrome is often related to ovarian induction therapy to prepare for in vitro fertilization. Ovarian hyperstimulation syndrome often manifests as ovarian enlargement with some degree of fluid accumulation that may include development of ascites and pleural effusions. Ultrasound imaging shows bilateral symmetric enlargement of ovaries that may become very large, such as over 10 centimeters in size, and the ovaries typically show multiple internal cysts that sometimes show a spoke wheel appearance. If you do not know what that looks like, go ahead and look up images. Clinical symptoms include things like acute pelvic pain, abdominal distension, and I would remember that in severe cases, one can even develop hemodynamic instability from large fluid shifts and third spacing. Ovarian hyperstimulation syndrome is more common in younger patients. That is all for now. We will continue discussion of ovarian masses, focusing more on malignant ovarian masses on upcoming episodes. After these episodes have been posted, a free downloadable study guide on this topic will be available at theradiologyreview.com. Thank you for listening. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I'll catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.